Welcome, Maria users and MMRC and PAMR members. It is so wonderful to see so many folks online. At the time of our last Maria user meeting, or MUM, in December of 2019, I could not have imagined that a worldwide pandemic would occur and that our next meeting would be 100% virtual, yet here we are. We filled nearly 400 seats for this meeting, which represents our collective enhancing reviews and surveillance to eliminate maternal mortality or erase work. I'm Julie Zaharados, Partnerships and Resources Lead for the CDC Maternal Mortality Prevention Team, and I'm here to provide a brief overview of meeting content and the meeting platform. I will also offer an overarching theme for our time together these next 2 days. As we embark on a meeting holding the weight of maternal mortality, we encourage you to care for yourselves and one another and be in community with one another. Before getting started, I want to acknowledge that last week was Black Maternal Health Week, and there was a proclamation of Black Maternal Health Week by President Biden. This week, the week was closed by the Black Maternal Health Conference on April 16th and 17th. Congratulations to the Black Mamas Matter Alliance and partners for an incredible week of activism, building awareness, and joy. I also want to acknowledge that yesterday we received a guilty verdict in the murder of George Floyd. There was so much that resonated in what Minnesota Attorney General Keith Ellison said after the verdict came down. The bouquet of people who testified for and documented what they saw that day. They didn't know George Floyd, but it didn't matter. They saw his humanity. Attorney General Ellison spoke to the fact that they assembled a team of Michael Jordans to work on the case and were criticized because no one would be able to pass the ball, and yet they did. Their team effort paid off. Our multidisciplinary MMRC reviewers and staff are a bouquet of people who document the humanity of women who have died. The team members are Michael Jordans, who must be able to pass the ball, because it's not just medicine alone that carries the ball, nor is it the system alone, public health generally, or individual community members and community-based organizations that carry the ball. We must pass the ball amongst all those who touch the lives of pregnant and postpartum women to get to the common goal, which is an end to preventable maternal mortality in the US. Today, we hold space to grieve together and to prioritize efforts to address the national crisis that is systemic racism. These are our meeting objectives for the next 2 days. Discuss efforts by CDC and partners from the Erase Maternal Mortality Initiative to facilitate an understanding of the drivers of maternal mortality and complications of pregnancy. Consider what interventions will have the most effect and inform the implementation of initiatives to prevent maternal mortality. Describe significant advances in the Maternal Mortality Review Information Application, fondly known as MARIA, and its use. Build on health equity discussions at previous MARIA user meetings or MUMs to actively recognize bias and inequitable processes and apply a health equity framework to the work of MMRCs. Create connections between state and city MMRCs, national partners, and federal agencies for the purpose of recognizing similarities, comparing challenges, and sharing successes in the various steps and overall outcomes of the maternal mortality review process. Before we get started, I must review some logistical items. I hope you had the opportunity to log in early and view our welcome videos from Dr. Rochelle Walensky, Director of CDC, and Dr. Wanda Barfield, Director of the CDC Division of Reproductive Health. Their comments set the stage for the significance of this event. We hope you've started to familiarize yourself with the platform. You'll find tabs for all of the key aspects of the event. Visit the Agenda tab to look ahead at the events we have planned for you. Every day we'll start with a brief welcome, followed by a plenary talk or experience from national leaders on the topics of health equity and racial equity in maternal health. We will also have concurrent sessions you'll be able to pick from one of 4 sessions from national leaders and your colleagues on pressing topics in maternal mortality review and prevention. We welcome you to comment and ask questions during the sessions through the chat feature. You'll find links to speaker bios within each session. In SwapCard, you're also able to click register for each event, and it will add you to the event in our internal SwapCard schedule, helping you to move through the event more easily, as there is so much to see and experience. Under the networking tab, you can search for colleagues and send them connection requests and messages. You can scroll through the list of profiles, and I have to say, I love all the photos. Or you can type information on the left to see results. You can enter the start of a name, a job title, or state, and folks will come up. Send them a connection request, and then you can send them a direct message. Please don't feel shy about reaching out. This is one of the coolest parts of the platform. Under the speaker tab, you'll find information about our wonderful speakers, and you can connect with them directly as well. Under the resources tab, you'll find great information compiled by our meeting organizers on topics such as self-care, storytelling, links to meeting resources, a demo of the newly refreshed reviewtoaction.org website, and a link to the meeting evaluation. Please do complete it. All plenary and concurrent sessions in the SwapCard platform will be recorded and available to you in this platform for 3 months following the event. Some of the videos will also be made publicly available on reviewtoaction.org. Each speaker has unique arrangements related to the availability of their resources or slides. You will see available slides or downloadable resources as speakers have made available under each session. At the end of each day, we will have a breakout session in Zoom for a limited number of MMRC representatives that serve in key roles on their MMRC. We wish that every registrant could participate in these spaces, but to keep them productive and focused on actions and key decisions, we needed to limit the participants. Individuals from your MMRC invited to these spaces received a direct email from Andrea Cornell at AmChip with instructions to register. While the breakout discussions will not be video recorded, notes will be taken in a centralized Google Doc and made available for viewing by all meeting registrants following the event. We have some light breaks throughout the event. Please know we encourage you to care for yourselves as you need to in this space. Step away if needed, stay hydrated, and move as you are comfortable. If at any time you'd like to engage in some structured self-care, visit the self-care resources page in SwapCard. And finally, we are thrilled to share that we are joined by Sunny Ben-Belkacem, a graphic recorder working with the See in Colors team, our virtual meeting managers. Sunny will be drawing visuals from plenary sessions and the discussions throughout the event and at breaks. And as we are able, we will be checking in with her to view her visuals and connect us to our conversations in new ways. We will be uploading images of her work to the resources tab throughout the event. That concludes my housekeeping remarks, but if you have any questions or concerns, please don't hesitate to contact Jennifer at textytalk.com, and we will get back to you quickly. Before I transition to our opening plenary speaker, Dr. Rachel Hardeman, I would like to highlight a storytelling theme for the meeting, as mentioned in the Know Before You Show communication. Tomorrow, you will hear Dr. Magda Peck encourage us to get truly personal, and Dr. Janelle Palacios will build on storytelling to humanize the stories of lives lost and to humanize MMRC processes and data gathering and reporting. Our thanks to Drs. Peck, Palacios, and to Ken Harris for their help with the storytelling experience. This is a profoundly important perspective as we engage more stakeholders in the work and tell stories in a way that resonates across audiences and drives necessary change. Thank you to those who submitted stories in advance via the Mentimeter link. The question we asked you to respond to was, what compels or calls you to support your MMRC? If you didn't have a chance to respond, visit the link in the chat box to add your answer. But what has been submitted already is beautiful, and I'd like to read aloud some of the answers. An MMRC is a human rights, women's rights project at its core. We ascertain, classify, determine, and assess maternal deaths and say these lives count. They matter. They are incalculable losses and alarm bells to society telling us we need to fix this. I want to identify and rectify those factors contributing to inequities in maternal death in my state. By serving and abstracting their stories, I honor the lives of women. I share the findings with colleagues and help prevent future deaths. In this way, my own life has meaning. It's personal for me. My career and passion were leading here, but then my pregnant family member died. There's no other way I would rather spend my time. And there are more. Your stories are indeed great, and if you haven't had a chance to share yours, please do tell it. Please be sure to take a moment to review your colleagues' answers and return to this space throughout the event. As part of the storytelling process, some of you may have heard of the 6-word story. A 6-word story is an entire story told in 6 words. It is a short narrative that can have all the emotional themes of longer stories. As I thought through what compels me to do this work, I came across 4 words inspired by something I recently saw in my neighborhood. Grief is love persevering. I saw this quote on a neighborhood church board, and it made my breath catch. But what is grief if not love persevering? The lawn of the church had been covered in 15,000 white flags in memory of those who have lost their lives to COVID-19 here in Georgia. There was that overwhelming visual set against the backdrop of our community, which has and continues to grieve and rally with the Black Lives Matter movement. All mothers were summoned when he called out for his mama. Yes, we were. And in addition to that, as if this were not enough, when I saw this sign, 8 people, 6 of them women of Asian descent, had just been killed in shootings here in Atlanta the day before. In the wake of that grief, the intersection of race and gender was painfully clear. And at the root of it all, this same intersectionality of race and gender also plagues our maternal mortality review work, as seen in the stark disparities in pregnancy-related mortality ratios for Black and American Indian Alaska Native women. In these stories of grief, the disproportionate impact of COVID and maternal mortality on communities of color and the recent shootings in Atlanta, there is a common thread. Society too often sees those most affected as vulnerable, weak, and maybe even disposable. And yet when we come to these stories, we know for certain that the women in them are anything but vulnerable or weak. When it comes to mothers, whether pregnant for 5 months or 10 months, in the delivery room grunting through labor and delivery, or nursing through cracked nipples and sleepless nights while our babies rest on torn abdominal muscles and our bottoms are trying to knit themselves back together, that moment when our baby's first smile appears is one of sheer joy. Women are not weak. Our own CDC Commission Corps officer, Dr. Shalon Irving, who was not afraid to call out inequity and work hard to eliminate it, was not weak. Tribal member and community activist Stephanie Snook, who regularly brought attention to issues such as missing and murdered Indigenous women, was not weak. Looking back on my early times as a mother, I know now I was not weak, even though they implied something I had done had brought on preterm labor at 34 weeks with my first daughter, Susanna. I was not weak when I nursed my preemie through illnesses, like the time I slept in Susanna's hospital bed with her when she was 18 months old and being treated for pneumonia, and a nurse looked at her history of asthma and said, I shouldn't have put her in daycare right away or given her formula over breast milk. As it happens, I had done neither of those things, and still my child was sick. Susanna survived, and she outgrew her asthma. I was left with the questions. Why do we blame women? Why don't we listen to women? When they cast us in this light and we start blaming ourselves for not being strong enough, not healing fast enough, not being perfect enough, there is a deep love and parallel grief that wells within me. How do we grapple with this? We grieve, we love, we persevere, and we repeat. In so many ways, the maternal mortality review work we do is an act of grieving. There is a procedural nature to the reviews, and like the rhythm of traditional mourning periods, the timeline from identification to review to reporting rounds out our own collective grieving. It is an honor to persevere alongside each of you in doing this important, incredibly challenging work. Your steadfast dedication and words inspire and challenge me every day. Our calls are always a bright spot in these weeks and months consumed with all too many national tragedies, too much death. Thank you for continuing to be steadfast in the work to end preventable maternal mortality while navigating these extremely challenging times. I look forward to considering with you our role as storytellers. Before I introduce Dr. Hardeman, I have to say, this quote is attributed to a show called WandaVision. I have not seen it, but my kids like it. In any case, it strikes me that this quote is attributed to the show lead, who shares her name with our CDC Division of Reproductive Health Director, Dr. Wanda Barfield. I am certain that our own lead, named Wanda, shares this vision, that together we can grieve, together we can love, and together we can persevere. And again, thank you for being here. Thank you to our partners and facilitators, and thank you to our speakers for helping us think more broadly, more clearly toward a better future without so much needless death. And now I would like to introduce Dr. Rachel Hardeman, who will speak to a structural racism analysis and equity-centered future for MMRCs. Dr. Hardeman is an endowed professor in health and racial equity at the University of Minnesota's School of Public Health and the founding director of the Center for Antiracism Research for Health Equity. A reproductive health equity researcher, she applies the tools of population health science and health services research to elucidate a critical and complex determinant of health inequity, racism. Dr. Hardeman leverages the frameworks of critical race theory and reproductive justice to inform her equity-centered work, which aims to build the empirical evidence of racism's impact on health, particularly for Black birthing people and their babies. Dr. Hardeman is the recipient of several awards for her work as an early career investigator. She is also active locally and nationally with organizations that seek to achieve health equity, such as the Minnesota Maternal Mortality Review Committee, where she serves as co-chair. Her full bio is available in the conference platform. Dr. Hardeman inspires us to pursue a deeper understanding of maternal mortality in the US and work to intentionally prioritize interventions to close the disparities gap. Dr. Hardeman.
Great. Good morning, everyone. I am honored and grateful to be here with you all this morning to share my thoughts and offer some ideas on a path forward as we work to close the maternal mortality gap. Let's see. All right, there we go. I want to start by centering us on what's most important, and that's the lives lost and injustices faced by far too many Black mothers and babies. I wrote this, the statement you see on this slide in the aftermath of George Floyd's murder, and I ask that you reflect on it now and take a moment to both lift up the Black lives lost, the Black babies that will grow up without a mother, the Black women like Breonna Taylor who will never have a chance to become a mother. "Mama," George Floyd called out, face pressed against the pavement with the knee of a Minneapolis police officer in his neck. "Mama, I'm through," Mr. Floyd yelled. George Floyd's cry for his mama resonates deeply with all of us. We all know what it feels like to need our mom in times of fear and distress. Yet, there is something else haunting about and painful in Mr. Floyd's words, a cry for help so profound it summoned all Black mothers in America, shaking us to our core, evoking images of our beloved Black sons and Black daughters stolen from us too soon. Stolen life and stolen breath, whether from police violence or entrenched inequities in maternal mortality, leave far too many of us calling out for our mamas. And just as George Floyd called out for his mother, Dante Wright, who died at the hands of police, also in my community, called his mom. As he was being pulled over, he spent his final moments talking with his mom on the phone. We all need our mothers, and far too many have been lost in our country. In full transparency, I am holding a lot of feelings in this moment. I'm a Black woman born and raised in Minneapolis, Minnesota, just 8 blocks from the image that you see on your screen of Cup Foods, where George Floyd was murdered. I'm grateful for the guilty verdict that was handed down yesterday. I'm also exhausted from the day-to-day work of being a Black woman, doing the work of health inequities while living amongst state-sanctioned violence. I'm also holding space right now for the pain and the loss of 15-year-old Ma'Khia Bryant at the hands of police, a police shooting that happened in Ohio not just an hour after the Chauvin guilty verdict was read. So because I need it, and I'm guessing some of you out there might need it as well, I'm going to ask all of us to just take a collective inhale and exhale as we embark on the important work of discussing maternal mortality today. And I thank you again for being here. So you heard from Julie about what compels her to do the work that she does. And I'm going to start by sharing a bit of my story. I'm here today because my life's work is to manifest racial justice so that all people, but especially Black women and girls, can live their full greatness and glory. It's what compels me to do the work that I do generally, and certainly what compels me to do the work of reproductive health equity, to serve on the Maternal Mortality Review Committee for my state. What also compels me is the story of my daughter's birth. I became a mother nearly 8 years ago. In fact, almost exactly 8 years ago. My daughter will turn 8 years old next Tuesday on April 27th. And on April 25th, 2013, I received a call from my OBGYN telling me I would need to come into labor and delivery because there was a trace of protein in my urine and concerns of preeclampsia. So after a slightly high-risk pregnancy due to a blood clotting disorder, I didn't hesitate to head directly to the labor and delivery unit. My OBGYN knew I had a birth plan. She knew I wanted to avoid an epidural, that I wanted to be able to move around while I labored, and that I, above all, wanted to avoid having a C-section. And because my blood pressure remained fairly normal and there were no immediate signs of complications and danger, she was able to listen to and honor my wishes, despite having received advice from her colleagues, unbeknownst to me at the time, that said, just C-section her and get it over with. I ended up spending 3 days in labor and delivery and went through a variety of induction processes, all while having conversations with my doctor and my husband and my doula. I'll spare you the 3 days worth of details of the process, but I will say that it was one that was incredibly empowering. And on April 27th at 10:35 p.m., my daughter, Layla Marie Medina, was born. And these are a few photos of the amazing birth team I had by my side. My parents and my in-laws and my identical twin sister, one of our amazing nurses, our OBGYN, Dr. Joy Hassler, and our doula, also part of our birth team. And, I often think about the privilege I had to cultivate the birth experience I wanted during my pregnancy, and how those 3 days I spent in labor and delivery could have been a disaster for so many reasons. I can still reflect on each point in which things could have gone wrong, in which my requests could have been ignored, where I could have been disrespected, where my autonomy and my power could have been stripped, but they weren't. And to me, that doesn't mean I count myself as one of the lucky ones. It means that I know that we as a healthcare system can do this. It gives me a clear vision that while, yes, we are fighting an uphill battle, that it is entirely possible to achieve the goal of dignity, of respect in childbirth, and to close the gap in outcomes that are experienced by Black and Indigenous birthing people. Having my daughter makes the work that I do to manifest racial justice that much more urgent. I tell her I'm fighting for America's paradise for her. This quote from the late author Toni Morrison from her book Paradise, I think sums up the work that I do in a nice way. Toni Morrison says the only way to change the order, she thought, was not to do something differently, but to do a different thing. And my colleagues and I actually started open up a paper that was recently published called Fighting for America's Paradise with this quote, because in fighting for the health and well-being of Black and Brown communities and for reproductive health equity, we have to do a different thing. We have to address the social, the environmental, the economic, the political, legal, educational, and healthcare systems that uphold structural racism and white supremacy. So people often ask me, how did we end up here? How did we end up with such stark inequities in maternal mortality and morbidity? And in this presentation, I don't offer any of those slides of the background of those data, because I think all of us here today are quite familiar with that reality. And I start my answer to this question of how did we end up here by saying we can't talk about this issue if we can't talk about history. We have to be able to talk about the history behind this current reality. So we have to learn about, understand, and accept the United States' racist roots. And I wrote this piece in 2016 in the New England Journal of Medicine, or it was published in the New England Journal of Medicine after Philando Castile was shot and killed by a police officer about a half mile from my office here at the University of Minnesota. And our goal with this piece was to ensure that our colleagues, clinicians, and researchers recognize that we cannot live our lives as though we don't each have a role to play in dismantling structural racism and supporting Black lives. So we wrote this call to action. And the first step we lay out is that we have to learn about and understand and accept the history of the United States and the racism that has led to contemporary inequities. And while we don't have time today to dig deeply into our history, nor am I a historian, I think that that without some historical context, it's hard to move forward. So I'm going to offer you a little bit. Starting with 401 years ago, in 1619, a group of 20 Africans were sold into bondage in Jamestown, Virginia. And I say this to suggest and to plant the seed that current inequities in maternal mortality are inextricably linked to the year 1619 and all those in between. And I'll tell you how in the next few slides. So these timelines are a reminder of how deeply ingrained our history is and all the ways in which white supremacy has taken new shapes and forms in order to maintain the status quo. So as you can see, Black enslavement comprises 60% of our country's history, and Jim Crow, so those state and local laws that enforce racial segregation, make up 20% of our history. So that's 80% of our country's history. And although Black Americans won the right to citizenship in the wake of the Civil War, the right to equality was not granted until a century later. And even then, most Black people were not allowed to exercise that supposed right. And we see that happening time and time again in states across our country. Today, white supremacy shows up in many ways, shapes, and forms, from mass incarceration, the war on drugs, certainly to police violence, and in many other social issues that plague our society. Our history has fundamentally shaped who we are today as a nation, and it drives the ideologies and framing in every institution where we work, live, educate our children, and offer healthcare in. And it certainly impacts the lens by which we view the maternal deaths in our states. So I'm going to walk you through an example of how this shows up. So here's an example of how historical notions of Black inferiority has seeped into the ways that we may approach our understanding, right, of maternal mortality, whether we realize it or not. So in Ibram Kendi's book, Stamped from the Beginning, he suggests that discriminatory actions wrought by self-interest come first. Then racist ideas are developed to justify them, and then they spread. So in other words, these racist beliefs were created to prop up the institution of slavery and justify the poor treatment of Black enslaved people. And then eventually the rationale for Black oppression multiplied in the colonial era and the early slaveholding republic. And the idea that African slaves or African enslaved people were hardy, right, or made for work, couldn't feel pain, had thicker skin, all were constructed simply to justify slavery. So in maternity care, James Marion Sims, the quote unquote father of modern gynecology, took those racist beliefs and translated them into racist actions, conducting research on enslaved Black women without anesthesia. The racist belief at the foundation of this practice was that, in addition to their status as enslaved people, Black women were considered appropriate subjects for his experiments based on the widespread belief that Black people experienced less pain than white people. So the racist belief of obstetrical hardiness became an influential racial folklore with medical theory and practice because it harmonized so well with the racial ideology that had already shaped Western thinking about racial differences and allowed for the justification of Black bodies to be used for research. So this photo here, this image here is of Anarcha, a 17-year-old enslaved woman, and one of Sims' primary research subjects. And he experimented on her for years, and after 4 years and 30 operations, he declared that he had perfected his methods. In addition, from the perspective of slave owners, this development, this declaration of a perfected method is notable because Sims' work meant that healed slaves could then retain their economic value. So now we've heard a little bit about the racist roots of the United States as it relates to maternity care. And the next part of our call to action in 2016 was that we have to now learn and understand how racism has shaped our narrative about health disparities. For example, the same beliefs used by Sims and others to justify the experimentation of Black bodies. So the idea that Black people are hardy, can't feel pain, have thicker skin. We see that manifested in contemporary ways in which healthcare is delivered. So a study published in 2016 found that 50% of white medical students and residents endorsed these same beliefs around not feeling pain, thicker skin, this hardiness, this notion of hardiness, that they endorse these same beliefs. And furthermore, what they found is that the ones those who endorse those beliefs were also more likely to score highly on the implicit association test, meaning that they had higher levels of implicit racial bias. So in thinking about how racism has shaped the narrative of health disparities, let's consider this notion of obstetrical hardiness and ask, how has the racist idea, belief, action, such as obstetrical hardiness, shaped the narrative about what we know about reproductive health inequities? And there are many studies we could highlight here. There are many incredible pieces done by incredible journalists across the country that we could highlight here. You saw some of the headlines and some of those pieces in Julie's opening remarks as well. The 3 studies I lift up as examples, today is one from Dr. Saraswati Vedam and her team at the Birthplace Lab, where they conduct the Giving Voices to Mothers survey and found that 1 in 6 women report experiencing one or more types of mistreatment, such as a loss of autonomy, being shouted at, scolded, or threatened, and being ignored when requesting or in need of help. I want to lift up Dr. Monica McLemore in UCSF and her team's work where they report the experiences of birthing people of color around disrespect during healthcare encounters, including experiences of racism and discrimination, stressful interactions with staff, and unmet information needs. And also I share the work of done by myself with my colleague, Dr. Laura Atanasio, using the Listening to Mothers survey, where we found that women who reported having declined care for themselves or their infant during the childbirth hospitalization period were more likely to report poor treatment based on their race. So the understanding we're coalescing around in the maternal mortality and morbidity space and the maternal child health scholarship space is that racism, not race, is a risk factor in reproductive health inequities. And undoing these deeply ingrained, racialized beliefs means dismantling widely held and pervasive beliefs in medicine, such as the notion of race being biological. So historically, race needed to be framed as biological in order to, again, uphold slavery. So thinking back to the obstetrical hardiness example, these racist beliefs and ideas were needed to uphold the enslavement of Black people. So doctors, for example, claim that people of different races had quote unquote peculiar, diseases or experienced common diseases differently because they had innately different bodies. We now know that to be categorically untrue, but those beliefs are still very deeply embedded in our systems and certainly impact the ways that we think about and frame and review our maternal mortality cases as well. And I think the narrative with respect to maternal mortality has often suggested that the cause of inequities in maternal outcomes are because Black birthing people or Indigenous birthing people enter into pregnancy less healthy, older, fatter, sicker, poor. And this victim blaming is not only inaccurate, but it props up a narrative that there's something pathologically wrong with Black people or other people of color. Rather, we should be considering the role of structural racism in causing maternal mortality and morbidity. So structural racism is a system built on white supremacy that has structured opportunity and advantage for some and disadvantage and lack of opportunity for others. It's the normalization and legitimization of an array of dynamics, historical, cultural, institutional, and interpersonal, that routinely advantage white people while producing cumulative and chronic adverse outcomes for people of color. And I think that this image in particular is incredibly important because as a field, we've gotten really comfortable talking about biases, implicit bias. And I think what's missing from that conversation is an understanding of how implicit bias informs structural racism and vice versa. So we're not born with negative biases towards any particular group of people. The biases we have are internalized, both consciously and unconsciously, have been primed, right, through our experiences, images, messages that we receive every day about who's normal, quote unquote normal, or who's desirable and who belongs, right, or who's different or undesirable and not one of us. And these messages are neither neutral nor are they random. In the United States, certainly whiteness is the dominant and privileged identity. It's socially constructed to justify the conquest and slavery and reified in laws, policies, both historic and current, that ensure that white people benefit disproportionately from the benefits of society and are protected, frankly, from its harms. White supremacy is baked into our country's DNA. And as a result, what's deemed as good or acceptable is normed to white people. And we all have, and we have all white, the effects, of these biases results in both individual and institutional acts. And that's where the structural racism piece comes in. Because of that, it structures our opportunities. It structures ability to get housing. It structures racial segregation, voter suppression, disinvestment in neighborhoods. It dictates where people can live, where they have if they have access to resources. It certainly has dictated how we design policies and practices that disproportionately benefit white folks and exclude other people from that processes. So I often offer redlining as an example of how structural racism manifests itself and continues to show up in contemporary health inequities, whether it's reproductive health, maternal mortality, or something else, COVID-19, for instance. And I think redlining is an important example because we have all gotten comfortable, at least in the public health space, of making a statement that where we matter lives for our health, or that zip code, the zip code studies that have shown that zip code can dictate life expectancy. My own work has shown that living in certain neighborhoods puts moms at greater exposure for police surveillance and disproportionately high police surveillance. What we found is it's associated with preterm birth. So where we live matters for health. But then we have to ask ourselves, how did that become the case? And redlining, the act of literally drawing lines on maps, right, to separate hazardous and declining neighborhoods from those that are desirable or considered the sort of best neighborhoods, has created these codified patterns of racial segregation, has created disparities in access to credit, and has certainly impacted homeownership rates in communities of color and Black and Indigenous communities, has dictated home values and credit scores. Even today in 2021, it's still very much apparent where these boundaries have been drawn in many cities. So that legacy of redlining and segregation and has led to a whole open the door to many other social determinants that impact the health and well-being of communities of color. So as we consider the role of structural racism as a contributing factor to maternal deaths, we have to be able to think through and understand these connections explicitly and how they may show up in the lives of the lost mothers that we care so deeply about. And so I often use this model to help guide that discussion, because I think we've gotten comfortable talking about these contributing factors of the social determinants of health. So things like lack of education, or if a mother had or didn't have access to high quality health care, housing instability, education levels, work opportunities, and things like that. But what we haven't done a good job of doing is really stepping backwards and thinking about what's at the root of these social determinants. So why do these social determinants matter for health outcomes? And at the root of that is structural racism and the policies, systems, and institutions that then dictate why education matters for health, why housing affordability and options matters for health and well-being. And I'm excited to share this conceptual model that I created with support from the CDC Maria Bias Work Group that was led by Dr. Elizabeth Howell, and our team was tasked with thinking about what definitions, starting out with what definitions of bias, right, should be added to the Maria form. And I think you're mostly aware now that what we came up with was structural racism, interpersonal racism, and discrimination. And what came from our work group, in addition to those definitions, was this model, which both supports the definitions developed for inclusion in Maria and offers an understanding of the connections between the forms of racism and their manifestation in healthcare delivery, and then the subsequent inequities in maternal mortality and severe maternal morbidity. We hope to have this published soon. It's under review right now, and I think it can serve as an important guide and reminder for maternal mortality review committees as they're reviewing cases to help with our understanding of what I just described, right, of these manifestations of racism that may have contributed to a maternal death that aren't always obvious on the actual in the actual case or in the hospital records, right, that we're reviewing at the time. So what's next? How do we move this work forward as we seek to honor the lives lost? So we've talked about, learning about and understanding the United States racist roots. We've talked about understanding how racism has shaped our narrative about health disparities. And I think we have to name racism, not race, right, as a contributing factor in maternal deaths. And we've talked a little bit about that. So I'm going to spend a couple minutes talking about how do we move this work forward as we think about the structure of our maternal mortality review committees, and then considering how that structure influences the function and thus the capacity to influence policy policy change, so little p policy as well as big P policy. So I hope to have a discussion particularly around those 2 points during the Q&A. So here are the 3 new contributing factors. I guess they're not so new anymore that I previously mentioned. Structural racism, interpersonal racism, and discrimination. I think for the sake of time, I won't spend much more time on this slide, but I really want us to start thinking about the challenges here, right? And I'm sure many of you have run into some of these challenges as you have done the work over the past year or 2. So, first, I think, at its core, racism has rarely been discussed among most MMRCs. I think we have a lot of members across different committees that are not familiar with are unfamiliar with identifying racism, and we sort of lack this baseline understanding, right? So I give talks about the connections between racism and maternal health all the time, and what I know and what I see is that there's a whole wide range of spectrum of sort of our people's understandings on these topics and this issue. And while I think we've done an incredible job over the past couple of years of really shining a light on these inequities, I think we still have a lot of work to do to ensure that there is a baseline understanding of what it means to say that racism is a fundamental cause of inequities in maternal mortality and morbidity. And then we have to get comfortable calling it out. I think often when given another option, right, we might default to the social determinants of health. Was it an environmental issue? Was it an issue of violence? Things like that. But, also being able to say yes, but also we have to remember what was at the root of why that social factor was at play is incredibly important. I think one of the things that, that many committees may be struggling with as we try to grapple with these new contributing factors on the Maria Forum is, are we trying to prove racism in the same way, or should we, be proving racism in the same way that we prove that a pulmonary embolism, for example, killed a mother? So questions around, what is the burden of proof? How do we identify racism in medical records? Certainly not all cases have that context, and in most cases don't have any of that context. One of the challenges I would love to discuss today is that, cases are often interpreted through the lens of the abstractor, who may not have a full understanding of these issues as well. And so we have, I think, a lot of work to do to think about what that means, and how to handle those challenges along the way. So, other considerations, I think the Texas Trigger Tool is an incredibly important tool that allows folks to drill down within the committee to ask another set of questions around the issue of how is racism operating here. One of the things I've been thinking a lot about is there a standardized set of research papers that can be reviewed by all team members, all maternal mortality review committee members, that grounds folks in the evidence base, right? That really offers a nice, solid information about what that reality is of both structural racism that's happening in people's lives outside of the healthcare system, and then how it shows up in different ways as they're accessing the healthcare system. So we're all starting out with a baseline level of sort of understanding of these issues. And I think also we need to understand the association of structural racism and maternal mortality in our own states, right? So every state should be able to have these analyses and should be able to frame the context of their reviews, right, within that context, and should be able to do so annually. So for Minnesota, and take Minnesota, where I am, for instance, we should be able to, as we review our 2020 cases and our 2021 cases, just as we will be thinking about them within the backdrop of the COVID-19 pandemic, we should also be able to have a discussion about the backdrop of George Floyd's murder in our community and its impact on community health and well-being, and be able to really think about that social context and why it might be critical or why it might matter for our discussion of maternal deaths in our respective states. So I'm going to skip to the fifth point in our New England Journal piece from 2016, because I think it's one of the most, if not the most salient point, and it's the way that I would like to kind of close out the discussion, my discussion with you all today. And that's the idea that we have to center at the margins. And what that means is we have to shift our viewpoint from the dominant narrative to that of the marginalized groups or groups. In this case, I would say for Black and Indigenous communities. And what we say in our article is that for clinicians, that means reflecting on how they arrived at their understanding of a diagnosis or a clinical encounter, and being willing to understand how a patient arrived at theirs. I think that a similar notion, a similar idea can be held within the work that we do in reviewing maternal deaths. We have to ensure that oppressed and under-resourced communities have access to decision-making and positions of power. So I'm going to talk a little bit about both of those, mostly those last 2 points in my final minutes. So what we know is that historical and contemporary views of economics, politics, culture, health are informed by centuries of explicit and implicit racial bias that normalize the white experience. And it certainly has normalized the process, right, by which we review our maternal deaths and the lens from which we review them. As a result, we have to be able to shift our viewpoint from the majority group's perspective to that of marginalized groups. Imagine if we started each case by taking a step back, right, and walking in the shoes of our lost mother, learning who she was, who her community was, and when she struggled, how she struggled, and why, and hearing from the voices of those who loved her, from those who were part of her beloved community. To center at the margins requires that we center the work of our maternal mortality review committees in reproductive justice, a framework put forth by a group of Black women in 1994 in response to the women's rights movement, which was led by and representative of a primarily middle-class and wealthy white women. Reproductive justice was created to defend and lift up the needs of women of color and other marginalized women in this space. And to achieve reproductive justice, we have to be able to analyze our power systems. What we know is that reproductive politics in the United States are based on gendered, sexualized, and racialized acts of dominance that occur daily. And reproductive justice works to understand and eradicate those nuanced dynamics, and taking that lens to the work we do to review maternal deaths, I think can be a really powerful path forward. Reproductive justice asks us to address intersecting oppressions. So we know that, and Julie said this in her opening remarks as well, women face multiple oppressions, whether it's gendered racism or some other intersections of identities. We have to ask ourselves, have we captured intersectionality in the maternal mortality review process? And what does that look like? Reproductive justice requires that we center the most marginalized, which I've talked a bit about already. And, the intersectionality of RJ, of reproductive justice, is both, an opportunity and a call to come together as one movement. And so I think it's an important thing to reflect on as we move forward and think about the path forward. And because of that, some of the questions we have to reflect on, the questions we have to be asking ourselves are, who are the members of our committees? Who do they represent? What is their lived experience? Does the composition, of our MMRCs reflect the center, or does it reflect the margins? How do we change that? How do we build a committee, and how do we build a institutional value for lifting up that lived experience? We have to ask ourselves, who's reviewing our cases? Do they have expertise beyond medicine? Can they bring a public health lens? Can they bring an anti-racist lens to the work? Do they offer a lived experience as they are reviewing the cases? And perhaps multiple people should be reviewing from each of those sort of lens, should be reviewing cases as we go. So I've also been thinking a lot about, how do we embed this work within the systems and institutions in which we do the work of maternal mortality review. And I think that, the path forward will certainly look different from one state to the next. And I think we have to be constantly asking ourselves, are we well equipped to understand the lived experience of racism as we review our the maternal deaths in our state? Some of that, I alluded to the educational piece, but certainly standardizing anti-racism training both nationally, but also across our, within each state, I think is incredibly important. We know that, certainly white supremacy and structural racism are show up nationally on a national stage, right? But the way it's manifested might look very different from one state to the next. And, we should have the ability to be able to leverage evidence at the state level to inform the local context as we review cases. We should consider as much as possible documenting on the Maria form, perhaps what zip code women live in, right? And thinking about then what are the factors, the social determinants within that zip code that could have led to the outcomes that we're grappling with. We know that structural racism is part of the water it is the water we swim in, right? And we need to be able to state that, to sit in that, and also to name it and ask and answer the question: is racism operating here, and how is racism operating here? My goal for you all today and beyond is that we become comfortable in our committees asking and answering those two questions. So in closing, I believe that all the solutions to eliminate reproductive health inequities and racial inequities in health and to achieve paradise, right, must be rooted in the material conditions in which these inequities thrive. And that means addressing inequities that are deeply, deeply embedded in American society. And I believe we can do it. I opened today with a quote from Toni Morrison in her book, Paradise. And I close with a quote from the same paper. It's a paper that I actually had the honor and privilege of writing with my twin sister, Simone Hardeman Jones, and my husband, Eduardo Medina. And this paper was published recently in the Journal of Health Politics, Policy, and Law, where we explore how we can find America's paradise through the new Biden and Harris administration, offering ways to tackle structural racism. And we close that paper by saying, we are fighting for the possibility of America's paradise for our son Leo and our daughter Layla and all the sons and daughters who so profoundly deserve it. And I believe the little people on the screen, my daughter Layla, who is now almost 8 years old, and my nephew Leo, who is 3.5, profoundly deserve it. And I think all of our sons and daughters deserve it. And I appreciate your time. I appreciate your patience today. It's been a rough couple of weeks in Minnesota, but I look forward to your questions and our discussion today. Thank you.
Thank you, Dr. Hardeman. Your words, as always, are so powerful. It's such a gift to have you here and involved in this work. There's questions coming in the chat. I have so many things that I would love to talk about. And I know, time is of the essence. I want to thank you for your work on the paper that will describe the use of Maria to document discrimination and racism and serving on that work group. As you'll see in the chat, there's many questions about that, right? Many MMRCs have shared with us at CDC that some struggle with the new contributing factor classes, including interpersonal and structural racism. So as you said, there seems to be this common struggle with concern over the amount of evidence versus speculation. How would you respond to your colleagues who are working through these challenges during committee review?
That's a great question. And I will fully say upfront, I don't have all the answers to how to handle that, right? Because I think it's a fraught discussion, right? It's hard. We have an incredibly robust now database or, evidence base, right? That tells us that at its core, structural racism has put Black and Indigenous birthing people in a position where they are more vulnerable to experiencing maternal death, right? And so, and that's never going to be, or that's rarely, if ever, going to be sort of documented in a medical chart. It should be, right? And that's a whole nother, discussion and project and, initiative that we need to be pushing, right? And I have incredible colleagues, both here at the University of Minnesota and across the country, who are working towards that and being able to understand, racism as a risk factor, and structural inequity as a risk factor, both for maternal health and other outcomes. But I think for me, when I review a case, when I know that, particularly as someone with the lived experience of being a Black woman in America, and what that means, plus the robust evidence base behind this, whether it's in the medical chart or not, it's there. It's the water we swim in. It's what women are navigating, or birthing people are navigating every single day. And some days it shows up bigger and bolder and more painful than others, right? I can say that the past 3 weeks of living in Minnesota during the Chauvin trial and while Dante Wright has been killed in my neighboring suburb, right, has certainly played a toll on my health and well-being. And I also think that this is why it's so important that we have people with lived experience, right, on our maternal mortality review committees to speak to that reality. And not just one person. It can't be one or two folks, right? It has to be a critical mass, because we can't expect the same person to speak up all the time, because that's perpetuating inequity and perpetuating that racism. So I think, I think for me, structural racism is a baseline. Like it's always there, and that's how I proceed. And I think also certainly having data. So one of the things my research center is working on right now is creating a data repository, both of measures of structural racism and an index to get at the multidimensional ways that structural racism shows up in people's lives, with the idea that with geographic identifiers, we can answer that question, is racism operating here from one state to the next? And having that dashboard, having those state level indicators has to be included in the analysis and the review of every maternal death, right? And saying, well, this woman, there may not be racism sort of documented in her medical chart, but we know she lived in this zip code, and her family said she experienced X, Y, and Z. That should be enough. We shouldn't be questioning the reality and the lived experience of birthing people of color.
Yeah, thank you. Thank you for bringing in these additional tools that we need. And some committees are beginning to operationalize the social determinants of health by zip code, by county, and also pulling in family interviews, because what we're seeing can, as you said, is very limited to medical records and can also, is through the lens of someone who's abstracting the record. So we need to be thinking more broadly. I was wondering if you can talk more specifically about community members joining committees and the role of patients with lived experience, whether it's severe maternal morbidity or lived experiences in racism on the committees specifically. I think that some committees are just beginning to do this while others may be more established. Yeah,
I mean, I think what I would say is it's, as I've said before, it's critically important. I think it's incredible. It's necessary for this work. I also recognize that it's a really, really tough ask, right? I think it's particularly for those with lived experience of maternal morbidity or severe, morbidity. It can be traumatic. I think recognizing that and holding space and honoring that is incredibly important. I also, and I think this differs from one state to the next, right? But we have to be able to compensate people for their time and their engagement. I serve on the Minnesota Maternal Mortality Review Committee, and I do it because I care deeply about my community and birthing people and this work for all of the reasons that you heard in my presentation. And I don't doubt that others do it for the same or similar reasons, right? And any community folks that we bring, might bring on, or people with lived experience, are doing it for the reasons that compel them. But we also need to recognize that commitment and what we're asking them to do and compensate them appropriately. I at the core of my work as a researcher is authentic community engagement. And you can't do that. You can't authentically engage with folks and ask them to give without ensuring that they have all of the resources that they need to live and thrive.
Thank you. And, the chat is kind of blowing up, but I'm going to try to control and focus as I can, because this is really exciting to be able to talk with you about this. Many of our maternal mortality supported programs, as well as others, have started to use anti-bias training for committee members to help build awareness and shared language for these discussions. But as we all know, we can't just rely on one training. How would you recommend MMRCs as committees build and sustain their committee as an anti-racist space, or make room for these questions?
Wow, that's a great question. And so I agree. We're not going to educate our way out of inequities, right? And disparities in maternal health, or any other disparities out there. I think that training, is certainly a important starting point. And I'll put a plug in for the work that I've been doing with the California Healthcare Foundation. We've created 3 online learning, e-learning modules around maternal mortality and morbidity in response to the legislation passed in California, requiring that perinatal care providers go through I think what they're calling implicit bias training, what I would refer to as anti-racism training. And I think it's an incredibly important starting point. I think that in order to move the needle past that, it's not a it's knowing that it's not a one and done thing, right? That it's ongoing. I mean, we're talking about 401 years of oppression and history, and B, like, racialized beliefs, right? That are, so we are inundated with them daily in the media, in the commercials we see, in the shows we watch, it's everywhere, right? Again, that water we swim in. And so relying on sort of a single tool is not enough. So it has to be done over and over and over again, and perhaps in different ways, right? Some of it, so we created e-learning modules. Certainly, I think there's an incredibly important space and room for live in-person trainings and discussions and things like that. I also think the incredibly important piece of this work is ensuring that discussions and change are being had at sort of within our institutions, right? So we can't do this work effectively if we're not working with leaders who believe in the work and believe in really moving the needle. We can't be effective if they don't understand or aren't able to apply an anti-racist lens to whether it's, they're in the C-suite of a hospital system, or are the, leaders of an MMRC, right? And so I think it's sort of, working from all different angles. And I think also being vulnerable enough and willing to reimagine, right? So maybe we say it, like, scrap it all and say this isn't working, or because it was built within a system that actually was never meant to keep Black birthing people safe and healthy, and we try something new. Don't ask me what that new thing is yet, but I think that, I think that should be on the table, and it's often not. We often spend our time, myself included, thinking about ways to fix a system that was actually never designed to keep Black people and Indigenous people and other people of color healthy.
Yes. I guess my mind is going in a million directions. I mean, so much of what you said was so powerful. I mean, the constant theme of victim blaming and why were they non-compliant? Why did they sign out ADA? You know, we have so many things that we see and that manifest at our table for maternal mortality review. I guess I'd like to, ask, what does it look like to capture intersectionality in the maternal mortality review committee process?
Yeah, that's a really good question. And I don't know that I have a single answer for that. I think that, you know, I think it's not, and this is like a whole struggle with just how to capture intersectionality generally, right? Or at least in like the empirical research space. Like this is a question we've grappled with for years. I remember trying to like propose a dissertation on measuring, quantitatively measuring intersectionality and being like, yeah, no, like being told that's not, yeah, that's a life's work, not a dissertation. And I think that there's some incredibly, great qualitative ways to be able to capture that and to be able to tell the story of a lost mother, right, who um, may have, these multiple sort of intersecting oppressed, identities that have led to structural inequity, and calling that out in the narrative, and really thinking about, um, you know, both or all of those identities as a case is reviewed, right? So, being able to acknowledge, well, she had this disability, and she was Black, right? And she was this, and I think a lot of it is just a matter of having that in our minds, right, as a part of the potential framework for reviewing a case. I think it's another question to think about what that means, um, for certainly for like policy recommendations. Um, and I think the big question is, we don't know sort of which of those identities mattered most, and perhaps it doesn't matter, right? But it's about just being able to call out that these intersections were at play.
Yes, thank you. We have about 8 minutes left, and there are lots of questions. But I think a lot of folks are asking for resources. We have a website that is a hub for resources, review2action.org. But you mentioned some papers that I think are really exciting, and would you consider there to be a standardized set of research papers that should be read by all MMRC members to ground people in the evidence base? And maybe we can, in follow-up or now, recommend some that you think are critical.
Yeah, I mean, I would be happy to make some recommendations. I don't think that there's a sort of standardized set that lives and breathes right now, but I mean, I certainly have thoughts on that. And I think that the incredible work being done across the country by folks. I mean, I named a few, but there's so much more that's happening. Both to think about, like Dr. Karen Scott's work, for instance, at UCSF, where she's building a patient-reported measure of obstetric racism, to the work of Dr. Dara Mendez, who's thinking about the ways that structural racism is impacting maternal mortality. And so I think that there's a nice sort of spectrum of evidence, peer-reviewed evidence that can help to really sort of add, anchor or situate teams in this space.
Great. And I guess I just want to acknowledge that in the chat, a lot of folks are asking about the Texas trigger tool that you mentioned. So I just want to say that this is something that the Texas review team is piloting alongside other states and will be publishing on it. So it is not available yet. I wanted to mention that. I also wanted to mention that in Dr. Barfield's recorded overview, she talks about our work with Black Mamas Matter Alliance, AMCHIP, and the Office of Minority Health. So there are more tools coming. We have heard you, and we are really excited that folks want more tools to do this work. Yeah, let's see. I wonder, will we have time to go to the graphic recording? I'm turning to our producers. Or are there other things, Dr. Hardeman, that you would like to highlight or touch upon?
I don't think so. I'd love to see what the graphic recorder has been up to.
Awesome.
great.
Yeah. Need to. I'm trying to look at it bigger. Okay. Beautiful. A structural racism analysis and equity-centered future for MMRCs. We all need our mothers. U.S. history is rife with racism starting in 1619. And this history has led to biased perceptions. Anti-racism trainings, equipping the review teams to understand the lived experience of racism. You know, something else that Dr. Barfield mentioned in the overview that I would like to lift up again is what we've heard from states is not to put the work of understanding racism on the people of color at the table.
Yeah, I think that's an incredibly important point. Yeah, I mean, I don't even know that there's much more to say about that other than I completely agree.
There were so many comments in the chat, and folks were really energized by your talk. I think one of the big themes comes out is more resources. So we know there's lots more work to do for sure.
There is. I was just reading some of the comments, great comments as well. No, I think there's. I constantly sort of sit in the space of like holding both like the reality, right, and the urgency of the fact that people are dying, right? We're losing people in our communities all the time, with, you know, and on the other hand, like holding this hope, right, and this forward momentum that I think is happening. It feels like it's not happening quickly enough, and I think, you know, one of the powerful parts for me of serving as a co-chair of the Minnesota Maternal Mortality Review Committee is that it's not just documenting the pain, it's not just documenting the bad outcome, but also thinking about like, what do we do better, right? How do we leverage what we learned from this lost mother to affect you know, system level change, you know, and really having those conversations about, you know, policy change.
Absolutely. There's so many intertwining moving parts here that you can see these folks in the audience are talking about and wanting to be able to engage in. Folks want that tool to do the kind of hot spotting of social determinants of health. And that is something else that is coming. Some states, as mentioned in the chat, have started to pilot their own based on local indicators, which is wonderful. And they're starting to get at what kind of structural racism influences are playing a role in the deaths that are being reviewed. There were some questions about specific zip code indices and hospital level. I think one of the big things that MMRCs grapple with is confidentiality and being able to keep everyone at the table engaged in the conversation and not feeling like they're singled out. So it is an important balance.
Yeah, absolutely. Absolutely.
Yeah. Well, I think folks are, you know, thanking you and appreciating your time. Again, thank you so much. In the resources tab, Sunny's graphic recording will be available. And then also maybe Dr. Hardeman, we can talk about what kind of papers and things to make available there as well.
For sure. I would be happy to. Yeah, it's been an honor. It's been a week that has felt, or a few days that has felt like a week here in Minnesota. But I'm grateful to have been able to spend the time talking about an issue that's, you know, certainly near and dear to my heart. So thank you for having me.
Thank you. Thank you so much. And now I would like to invite you all to join one of the following concurrent breakout sessions. You will be able to do this tomorrow as well. The options for today: recognition and response to obstetric emergencies by non-OB responders with ACOG, community-based grant programs implementing actions informed by MMRC data with Tennessee and Ohio, conducting informant interviews with the Georgia and Mississippi teams, and small numbers reporting with the CDC maternal mortality prevention team's EPI section. These will be available on demand if there's any you want to watch or rewatch later. So thank you again, everyone.